So I'd like to thank the organizers for the invitation. This has been a great meeting. I hope you guys are all enjoying it. But I think, as Dr. Al-Ghazi told you, it's been a really remarkable time for those of us in the field of melanoma. I've only been doing this for 10 years. I know some people have been doing it a lot longer, and God, when I started, it was pretty depressing, I'll tell you that much. But now it's just really, really remarkable. And the advances have been both in targeted therapy as well as immunotherapy. What I want to talk about today, using some of the data from the melanoma literature, are some lessons we've learned on how to use immunotherapy. I know some of you may not treat this disease very much, but I think more and more immunotherapy is going to be applied to other more common diseases. So here are my disclosures. And just in the way of background, in 2011, these were the drugs that we had that were FDA approved for melanoma. It was quite slim pickings. We had chemotherapy, interferon for adjuvant therapy, and then high-dose IL-2. And then in 2011, with the approval of Ipilimumab, it kind of started this cascade of approvals, which were really based upon findings such as the finding of frequent BRAF mutations in melanoma in 2002, as well as the understanding of immunologic checkpoints and how we could take advantage of that therapeutically. And so Dr. Al-Ghazi spoke about vemurafenib, dabrafenib, and trametinib, but what I'm going to be talking about primarily is the data regarding the use of Ipilimumab, which is the anti-CTLA-4 antibody, as well as pembrolizumab and nivolumab for advanced melanoma. In terms of lessons learned, we have learned a lot over the past few years about immunologic checkpoint blockade, and I do want to focus on immunologic checkpoint blockade, despite the fact that there is progress on other cytokine therapies, virolytics, and so forth. And one of the important lessons is that modulation of immunologic checkpoints can induce clinically relevant anti-tumor radiographic responses and improve overall survival. And the initial lessons were really learned from Ipilimumab. Just in terms of mechanism of action, this is a little bit complicated, but what you can see here on the bottom is an antigen-presenting cell, up top's the T cell. And to understand how Ipilimumab works, you have to understand a little bit how the T cell is activated. So initially, what happens is an antigen-presenting cell will present an antigen in the context of an MHC complex to the T cell receptor. And this is kind of signal one in turning on the T cell. To use an automobile analogy, it's kind of like the light switch analogy that you just saw for targeted therapy. This is like putting the keys in the ignition of a car. But for full activation, you need a second signal, which happens when B7 on the antigen-presenting cell binds to CD28 on the T cell. This is signal 2. This leads to full activation. This is like putting your foot on the gas pedal. This turns on the T cell, allows the T cell to go and do what it needs to do. But in terms of regulation of this, as soon as this occurs, CTLA-4, which is within the T cell, begins to migrate into the immunologic synapse in the middle. And when it gets there, CTLA-4 can bind to B7 with greater affinity than CD28. And when this happens, you get an inhibitory signal. This is like putting the brakes upon the immune system. Okay, so what Ipilimumab does is it basically blocks the ability of CTLA-4 to bind to B7. When you get that, you get enhanced T cell potentiation. So this is data from the first phase 3 trial that was published by Steve Hody, where about 700 patients were randomized in a blinded fashion to either Ipilimumab with a GP100 vaccine, Ipilimumab with placebo, or the vaccine plus placebo. And what you see here is a survival curve. This is the vaccine line alone, and what you can see is whether you got Ipilimumab alone or in combination with a vaccine, you had improved survival versus the GP100 vaccine alone. And I think most of the folks in the melanoma field would agree that this was essentially a placebo arm. So if you look at the 1-year overall survival, it was improved from 25% to 46% with Ipilimumab. At 2 years, it was 14% over 24%. And what I want to point out are two things on this curve which I think are very important. One is this. You don't see a split in the survival curves for about 3 months from when you start therapy, and this is really, really important. As you heard with the targeted therapy talk, with targeted therapy we can see efficacy, we can see anti-tumor effects right away, but that's not the case with some of these immunotherapies. And so for here, if you're going to treat a patient with immunotherapy, at least with Ipilimumab, who has rapidly progressing disease, who perhaps has a short expected overall survival, they're unlikely to actually get a lot of benefit from this drug. So you have to pick the patients very carefully. But if patients do get benefit, what you also see is what we call this tail of the curve phenomenon. So if you get out around 2 to 3 years, you can see that the survival curve flattens out. Very few patients at that point do end up dying from disease. And so patients who do benefit, although it may take some time to see that benefit, if they do benefit, that can be durable and long-lasting. And this is kind of a hallmark of immunotherapy, of effective immunotherapy. This sort of tail of the curve was borne out in the larger retrospective series, which was initially reported by Steve Hody and then just recently published in the JCO, where they did a meta-analysis looking at patients treated on 10 trials of Ipilimumab, and this was over 800 patients, as well as combined to the phase 3 Ipilimumab trials as well, looking at around 800 patients again, and then used cooperative groups and retrospective data for comparison. And what you can see is that you still get that tail of the curve phenomenon in this retrospective study. The median overall survival at this point was about 11 months. 3-year overall survival rate for the entire population was about 22%. And so again, you can kind of see that tail of the curve. With Ipilimumab on the Steve Hody trial, the 2-year survival was about 20-25%. That's maintained at 3 years, and a recent publication also showed that that can be maintained to 5 years or more. So again, if you make it out to 2 to 3 years with this drug, you're likely to do quite well. Another lesson learned is that we can see atypical patterns of response with Ipilimumab. With targeted therapies, with chemotherapy, if the drug's going to work, we expect it to work right away. On the other hand, we can see delayed responses with some of these immunologic agents. This was a patient treated at Memorial who had very small burden of disease within the liver at baseline. This patient got the 4 doses of Ipilimumab, and as you know, this is an IV agent. You get it once every 3 weeks. We do 4 doses, and then we observe. And then we do a scan around week 12. And this is what the liver looked like. Of course, if this was a patient with BRAF melanoma treated with vemurafenib, this is progression. Or if this is a patient treated with chemotherapy, this is progression, and we switch therapy. But when we saw this patient, he felt remarkably good. Lab work looked okay, and we actually opted to observe. And what you can see, 8 weeks later, with no further therapy, this is what the liver looks like. And again, 36 weeks after therapy, this is what it looks like. And so this patient was treated in July of 2006. He's doing well today. And so again, this is something that you have to kind of learn to look out for and expect. If you see a scan like this in a patient who's treated with Ipilimumab who's actually doing well clinically, you don't need to change course at that time. And so because of these alternative treatment responses we've seen with Ipilimumab, Jed Wolchek and others developed what's known as immune-related response criteria to take that sort of delayed response into account. And so a framework that we use to kind of manage these patients treated with Ipilimumab is that we treat them with the induction course of therapy, and then we get a scan after completing the 4 doses. Obviously, if the scan looks good, if the patient has a stable disease, partial response, or complete response, then we continue to observe without the need for further therapy. If the patient has clear progression and is clinically not doing well on that first scan, then we switch therapies. But if you have a patient who has radiographic evidence of disease progression but is clinically doing okay, it is perfectly reasonable to observe, repeat a scan within some reasonable framework of time, usually 4 to 8 weeks afterwards, and look again, because some of the patients who had progression at this point are actually going to be doing well at this later time point, okay? And so with Ipilimumab, with all of the clinical trials that we're doing with some of these novel immunologic agents, we always build in the need to confirm progression before changing therapy. You know, we're always used to confirming response before we say it's a good therapy. Now we actually have to confirm progression as well, and so that's a really important point. Second thing that we've learned from this experience is that there are additional targets that may be better than CTLA-4. And just to go back a little bit to biology again, where Ipilimumab works is really in the immunologic periphery. This is where the antigen-presenting cell is presenting antigen to the T cell. This occurs in the lymph nodes. And again, as I said before, Ipilimumab or anti-CTLA-4 blocks this interaction between the dendritic cell and T cell. But after this occurs, the T cell has to get to the tumor microenvironment. And this tumor microenvironment is where nivolumab and pembrolizumab work. When I talk to patients about what pembrolizumab or nivolumab do, I kind of describe tumor cells as having kind of a force field or a shield surrounding itself, and that force field is basically PD-L1 or PD-L2. So that if an immune cell tries to get there, it's kind of shut off or inactivated by the interaction of PD-L1 and PD-1. And so basically these new PD-1 antibodies or PD-L1 antibodies block this interaction between PD-1 on the T cell and PD-L1 or PD-L2 on the tumor cell. And so that's how these PD-1, PD-L1 antibodies work. There are a number of agents that have been studied. What I'm going to focus on are the two approved agents, nivolumab, which is the BMS agent, and pembrolizumab, formerly known as lambrolizumab by Merck. The first drug that we had a great deal of experience in melanoma was nivolumab. And this is data from the phase 1 trial, which looked at patients with tumor types other than melanoma, but we did have a large sample set of 97 patients who were evaluable for response with melanoma. These patients were treated with various doses of drug going as low as 0.1 milligrams per kilogram and as high as 10 milligrams per kilogram. And this is the waterfall plot. Overall response rate used in traditional criteria was 31%, and to put this in context, with ipilimumab, our response rate's on the order of 10%, with chemotherapy, it's on the order of 10%. Interestingly, the likelihood of response was not dose-related. We saw responses on every single dose level that we treated, as low as 0.1 milligrams per kilogram. This is the waterfall plot with lambrolizumab or pembrolizumab, and again, response rate is comparable at 38%. What I do want to draw your attention to is the complete responses we saw in this study in about 10% of patients as well. And again, this is quite remarkable because we did not see complete responses like this with ipilimumab as frequently. In terms of survival, with nivolumab, the median overall survival was about 17 months. Remember, with ipilimumab, the one-year overall survival rate was about 46%. And this is data, again, from the phase 1 trial. The one-year overall survival rate was 62% as a single agent with nivolumab. Two-year survival was 24% for Ipi in the HODI trial, and it's 43% with nivolumab. So again, very, very, very promising data. Very similar data with pembrolizumab. This was a trial where patients were treated on 2 different doses of pembrolizumab, either 2 milligrams per kilogram or 10 milligrams per kilogram. The one-year overall survival rate's on the order of 60%. Again, so efficacy with the PD-1 antibodies, again, seems very promising across trials, which you have to be cautious about when you compare it with ipilimumab. There are a couple of phase 3 trials looking at nivolumab versus chemotherapy. One was the so-called Checkmate 66 trial, which was a frontline trial where nivolumab was compared against DTIC in patients who were BRAF wild type who had not received prior therapy. Primary endpoint of Checkmate 66 was overall survival. And Study 37 was a second or third line trial where patients who had previously received therapy with ipilimumab, and if they were mutant for BRAF, they must have had a BRAF inhibitor as well. They were randomized on a 2-to-1 ratio to either nivolumab or chemotherapy. This was dealer's choice, and primary endpoints were both response rate and overall survival. So this is the study schema for the frontline trial, where patients, again, with advanced, previously untreated melanoma who were BRAF wild type were randomized on a 1-to-1 ratio to nivo and placebo, or dacarbazine plus placebo. Randomization was stratified by PD-L1 status. It was positive versus negative, also versus indeterminate, and M stage as well. And again, on this trial, patients were allowed to be treated beyond the time point of initial progression because of the possibility of late responses. This is the waterfall plot from that frontline trial. Overall response rate for nivo was 40% versus chemotherapy, 14%. And this is the survival. So there was an improvement in the one-year overall survival rate. Nivo was 73%, chemo 42%. The hazard ratio was 0.42. This was highly statistically significant. So again, this is important. This is frontline data for nivolumab in the BRAF wild-type patient population. The second-line trial hasn't been published yet, but here patients with advanced melanoma who were previously treated, again, were randomized on a 2-to-1 ratio to nivo versus chemotherapy. In this case, it was dacarbazine or carbotaxol, dealer's choice. Again, patients were treated until progression. And here, patients, again, were stratified by PD-L1 expression, BRAF mutation status, as well as response to prior CTLA-4 therapy. In terms of response, the waterfall plots are similar. The response rate in the second line was perhaps a little bit less than what we saw frontline, 32% in the second-line trial. For chemotherapy, it was 11%, and this was as reviewed by central radiology. Now, this is important. Of the 120 patients treated with nivo in this trial, 37 patients continued treatment beyond clinical or resist progression. And 10 of these patients, despite the fact that they had progression before, responded subsequently, and that's these patients in red here. I just want to highlight this patient here, who clearly on the spider plot had growing disease up until 12 to 18 weeks, followed by subsequent shrinkage of disease. This patient here, interestingly, was doing well. Then around 6 months of therapy developed a new lesion, but despite that new lesion, continued on therapy and then achieved a near complete response. So again, with these agents, we have to get used to those novel patterns of response to therapy. The FDA label for nivolumab, its dose is 3 milligrams per kilogram, IV over 60 minutes every 2 weeks. And the indication in melanoma is for unresectable or metastatic melanoma with disease progression following Ipi, and if BRAF V600 mutant after progression on a RAF inhibitor. This was also just approved for squamous non-small cell lung cancer as well. Pembrolizumab is approved at 2 milligrams per kilogram, IV over 30 minutes every 3 weeks, so there is a scheduling difference, at least in the FDA label, so this can be given a little bit quicker and a little less frequently. The indication, though, is the same, unresectable or metastatic melanoma with disease progression following Ipi and if BRAF mutant after progression on a RAF inhibitor. But despite this, the NCCN guidelines say this: there's consensus among the NCCN panel that both drugs, both nivo and pembro, have higher response rates and less toxicity compared to Ipi, and that both drugs should be included as an option for first-line therapy. So this is kind of another one of those interesting settings, kind of like with the pertuzumab setting, regarding what do you do for patients. Clinically, I think a lot of our inclination is try to get patients access to a PD-1 antibody as quickly as possible, whether on a clinical trial, optimally, or perhaps commercially. Based upon this data, we do have frontline data for nivolumab, and now we do have the consensus guidelines by the NCCN for this. There's a lot more that we know, but the last point I'm going to talk about now is that combination of checkpoint blockade with other immunologic agents may result in dramatic clinical responses. And Dr. Al-Ghazi kind of spoke a little bit about this, about the power of the combination of CTLA-4 inhibition with PD-1 inhibition. Jed Wolchuk, Mario Schnoll led a phase 1 trial of nivolumab plus ipilimumab in patients with melanoma, and this is the waterfall plot from 53 of the patients. And here, the overall response rate by modified WHO criteria was 40%. So that's impressive, but what's also even more impressive is the depth of these responses, because many of these responses were very, very deep, with over an 80% response, if not a complete response to therapy, and these responses were quite durable. When you look at 1-year survival, again, remember where we started. We were about 20-25% for Ipi in 2011. Now with the combination, we're looking at between 85 and 94% 1-year survival with combination therapy in this phase 1 trial. 2-year survivals around 80%. And to think that we were just at, for instance, 25% with Ipi in 2011, and now we have this data, I think is really, really remarkable. Just to kind of look at the efficacy of CTLA-4 and PD-1 or PD-L1 antibodies across trials, which you have to, of course, do carefully. With the HODI-IPI trial, we saw an overall response rate of 11%, a 2% complete response rate, median overall survival of 10 months, and then 1-year, 2-year overall survival rates there. I didn't talk at all actually about the PD-L1 antibody trials, but response rates with these were a little bit higher, and the 1 year, 2 year overall survival rates haven't been reported. But then when we look at the PD-1 antibodies, whether it be Nivo or pembrolizumab here, response rates again seem higher, but 1 year, 2 year overall survival rates, where they're available, also seem improved compared to Ipilimumab. And then we look at the combination data. Now here we're talking about overall response rates, 43%, a complete response rate of 17% on this trial, 1 year survival rates around 90%, 2 years in the 80s. This combination is being studied in a randomized fashion versus Ipi alone or nivolumab alone. That has completed accrual, and we hope to have that data by 2016. The added efficacy comes at the cost of potential toxicity. And I know I have not spent a lot of time talking about toxicity of these agents. That I think we can perhaps talk offline if you have any questions, because that is somewhat challenging. But when we look at the toxicity with combination therapy, it can be pretty significant. Cohorts 1 to 3 were various doses of Ipi and Nivo together. Cohort 8 was kind of an alternative schedule. But you can see that almost all patients have some sort of toxicity. When you look at grade 3 to 4 toxicities, it's in the 60% range. So this patients can experience toxicity. What we do see frequently is rash and diarrhea, but the rate of grade 3 to 4 toxins is relatively manageable if you treat it early. But what I do want to point out with this combination is that a lot of the toxicity seen, particularly the grade 3 to 4 toxicities, were lab abnormalities only. So hepatitis, increase in the amylase, increase in the lipase. The increase in the amylase and lipase has been thus far basically a biochemical finding only. And it does come down either with observation or with steroids. The hepatitis has to be treated with steroids, but it's almost always easily manageable as long as you treat it aggressively. And so the general approach to some of these toxicities you see when patients are on some of these agents is one, you always have to include drug-induced autoimmune toxicity in the differential. And frankly, I think I always assume that that is the case until I find another cause. These toxicities can affect any organ. Commonly, it's going to be cutaneous toxicities like rash and pruritus. With Ipilimumab, we're very conscious about looking for diarrhea or colitis. The endocrinopathies, the hepatitis can be seen, although less commonly. And with pembrolizumab and nivolumab, we're very conscious about potential pneumonitis, although the incidence of pneumonitis it's about 1% to 2%, so it's not that common a finding. In terms of the management, and this is just an example for what we do for colitis, as soon as a patient has any sort of GI complaint, whether it be gasiness, bloating, or frank diarrhea, we do initiate a very bland diet. Sometimes bring them in if we're worried, make them NPO, put them on IV fluids, and we do monitor them very closely. In our clinic, we actually do nursing calls every day if we're concerned. But as soon as there are 4 or more bowel movements a day, then we do hold treatment. We do look for C. diff, which we actually do find, interestingly, modestly frequently. And then we can try things like budesonide, Imodium, or Lomotil, although, to be honest, it doesn't tend to work very often. We're very quick to jump directly to steroids. We can do 1 milligrams per kilogram of steroids. In our experience at Memorial, when we look back, we actually treated about 30 to 35% of patients with steroids, which is higher than what has been reported in the clinical trials, but I think our threshold to use steroids is very low. With prompt initiation, we find that we just keep the patients out of the hospital and avoid problems down the line. And if the steroids are not working, we're very quick to jump to infliximab. In our experience, about 10% of our patients were treated with infliximab, and that almost always works to knock out the toxicity. There's a lot that we still don't know, and each of these topics can be another entire lecture, but the role of various T cell subsets, whether it be regulatory T cells or the effector T cells, has still to be further elucidated. There's a lot of work looking at biomarkers predictive of response. And some work that was recently published by Tim Chan's lab by Alex Snyder looks at things like mutational burden, which does correlate with response to these immunotherapies, specifically the development of immunologically relevant neoantigens seems to be very predictive, and those can potentially be identified. We are looking at the clinical efficacy of checkpoint blockade between CTLA-4, PD-1, and PD-L1, and we are looking at various combination strategies, either with various immunologic agents combined with targeted therapy or radiation therapy as well. There are a lot of other immunologic checkpoint receptors. Many of these are being targeted in ongoing or planned clinical trials. So I think there's much more to come. So in conclusion, we do have a number of new immunologic therapies based on that increasing kind of understanding of immuno-oncology and our ability to make these antibodies. We do need further work to identify biomarkers predictive of response for these patients, and we do have to figure out how to best combine immunotherapy with other immunologic agents, targeted therapies, or other. And although I think we made a lot of progress, clinical trials and studies into how to improve outcomes is still required. So I'll leave it at that and take any questions. Thank you.
Great, thank you. Just one quick question.